Good evening. Welcome to a webinar on multiple myeloma from the Indian Society of Oncology. It's a great pleasure to welcome everyone on board. With permission of the President, Dr. Toprani sir, we will like to start the webinar.
Yeah, please go ahead.
Thank you, sir. So we have for the starting batsman none other than Professor Hemant Malhotra, sir. I think pan India, no one needs an introduction. So I request sir, who is right now the Director of Oncology Services at Shri Ram Cancer Center, Mahatma Gandhi University and Medical College, Jaipur. Sir, please, I will request you to start this webinar on multiple myeloma.
Thank you, Sumant, and good evening, everybody. I'm Hemant Malhotra from Jaipur. I'm the incoming president of the ISO. With the permission of the ISO, Dr. Toprani will start today's webinar, and this is one of the several series of virtual CMEs which we are doing under the auspices of the Indian Society of Oncology. And I can tell you that these virtual webinars have been quite successful, more than 200 plus attendance in each of them. And this time we have chosen a hardcore hematology topic, which is multiple myeloma. Multiple myeloma, all of us know that even though it's not a very common cancer, but it's a disease which every medical oncologist and every hematologist sees sooner or later. And once a diagnosis is established, once the CRAB features are there, once there is an indication for treatment, then you basically decide whether the patient is a candidate for transplant, non-transplant. And now you have a whole bunch of treatments, drugs, new drugs, targeted drugs, monoclonal antibodies, the antibody drug conjugates, bispecifics, bone marrow transplant, CAR T cells. I think the progress which has happened in myeloma is unparalleled. Every few months, a new molecule for myeloma comes. I remember the time when I started medical oncology some 30, 35 years back. There just used to be melphalan and steroids and dexamethasone, and we used to give like 48-hour infusions of vincristine, doxorubicin, which was known as the VAD regime. But we now really moved forward in myeloma. And I have absolutely no hesitation in saying that the progress which has happened in this disease, I don't think there is that much progress and those many options of treatment for any other disease. And we really have a fantastic faculty for you today. The hard work of Dr. Savita, Dr. Sumant, they have managed to string together the country's leading people who treat myeloma. And I think they'll be introduced to you one by one. The first talk, as you can see on your screen, is about CAR T cell therapy. So, as of today, all patients of myeloma have to have a autologous stem cell transplant. And even though it increases the disease control by several years, it doesn't cure the patient. And every single patient will sooner or later relapse. What are the options when these patients relapse? We now have a new option which is coming on the horizon for us in India, the CAR T cell therapy. Very happy and proud to tell you that there are at least two CAR T cell, the BCMA CARs, which we will hear in a little while, two trials ongoing in India. One is from an important product, and one is from a product which is exclusively developed in our country. So I think all of us are very keen to hear the status of CAR T cell therapy in multiple myeloma. And there is none other than Dr. Jay Chandra who is going to talk to us about this today. Dr. Jay Chandra is senior medical hematologist and oncologist at the famous Adyar Cancer Center. He is a stem cell physician and he's a CAR T cell and cell therapy expert. And I think he's the most appropriate person to talk about this special therapy in multiple myeloma. So I'm going to hand over to Dr. Jayachandra. Dr. Jayachandra, over to you. And thank you very much. Hope you enjoy the evening.
Good evening to everyone. Thank you, ISO, for this great opportunity to talk on CAR T cell therapy in multiple myeloma. Thank you very much, Hemant sir, for a warm introduction about me. And as Dr. Hemant Malhotra has told, myeloma is not a very common disease. However, with due to the elderly population and our population shifting towards more of an elderly population, we see a lot of myeloma, and there's a rise in myeloma diagnosis now because of more awareness with the nephrologists and other people. So we are seeing more number of myelomas compared to the yesteryears years. And this is the landscape of myeloma treatment for all the residents. So initially they have a asymptomatic phase, which we call it as MGUS or smoldering myeloma. And once they become symptomatic, they become an active myeloma. And then subsequently we treat them and get into remission. We consolidate them with the autologous stem cell transplantation and then keep under maintenance. The remission period is for some time. At some point of time, it relapses, and then we do the second line treatment, and then subsequently we go on to get some more remission, and then subsequently have a third second relapse, and we give third line treatment and then get into remission. And some point of time we are out of drugs. Basically we have a relapsed or refractory disease, and through the myeloma there will be some chance of the state clones may change, and we can have clonal evolution, and also we can have aggressive myeloma, which can set in over the time after few relapses. So this is a landscape of myeloma patient, how he gets treated. So then subsequently we'll go on. We need to find a few definitions. Basically, what is exposed and what is refractory. So exposed is just exposed to those lines of treatment. So either PI exposed, PI is bortezomib most commonly, or imide exposed, maybe a lenalidomide or pomalidomide. So exposed in this previous line is different from refractory in the previous line. So basically, patient should have a refractoriness to the previous therapy or imide is something called refractoriness. So there must be we should all identify the difference between exposed and the refractory treatment. And let me define few things like double class, triple class, and pentaclass. So double class refractory or exposed means either patient should be a double class refractory means refractory to one PI, which is most commonly bortezomib or carfilzomib, and one imide, which is most commonly not thalidomide, either lenalidomide or pomalidomide. We call most commonly it's a lenalidomide, which is double class refractory. We call bortezomib len refractory. And triple class is one PI, one imide, and one anti-CD38 molecule, which commonly we have is daratumumab. And pentaclass refractory is two PIs, which is carfilzomib and bortezomib or exazomib maybe, two imides, which is lenalidomide and pomalidomide, and one anti-CD38 molecule is called pentarefractory class. So basically, we need to find these definitions, and moving on, what we need to see, what is the real outcomes of patients before we have CAR T in this in our country. So this is data, very old data from 2015, about 10 years old data, when we used to have only bortezomib and lenalidomide. So that at that point of time, we didn't have carfilzomib or daratumumab or pomalidomide in our armamentarium. So if you look at those survival, when we had one double class refractory, the median PFS was just only 5 to 6 months in double refractory patients. And subsequently, we had patients, we had the drugs like carfilzomib, pomalidomide, and daratumumab to access for good access for our patients. And came the definition of pentaclass refractory, basically exposed to carfilzomib and carfilzomib and bortezomib, exposure to imides like lenalidomide and pomalidomide. And most of our patients are exposed to either quadra or pentarefractory patients. And if you look at those patients who have pentarefractory disease, this is the data from 2-year-old data, which was published in 2022 journal. The pentarefractory PFS is hardly 5 to 6 months. Is the pentarefractory class. So we have a PFS of only 3.88 months in the such patients who are pentarefractory. And if you look at the PFS in the pentarefractory, again is 6 point. Another data is also showing about 6.63 months only. So coming on to the therapy, what is something which is novel in this pentarefractory patients? The BCMA targeting, which is B cell maturation antigen targeting therapy, is something which is novel and is going to improve the PFS in such patients. And if you look at these patients who are pentarefractory, if you look at non-BCMA treatment versus BCMA treatment, the BCMA treatment median PFS was 17 months versus 6 months. This is across the board, includes all BCMA monoclonal antibody, BCMA BiTEs, and BCMA CAR-T. So if you look at these patients who are penta-refractory to all the other five classes of drugs, only BCMA-directed therapy would improve the survival in such patients. So what are the available targets? We have novel targets. So basically, we have one drug called selinexor, which is a SINE inhibitor, and it has a data, but not very much promising, but it's not available in India. So again, BCMA targeted monoclonal antibody belantamab, it has its own fallacies and toxicities. It is re-emerging, but it has a severe toxicity in terms of eye toxicity. We have teclistamab, which is a BCMA targeting BiTE. We have talquetamab, which is a GPRC5D targeting BiTE. And we have elranatamab, which is BCMA targeting BiTE. And we have a lot of bunch of anti-BCMA CAR-Ts. Of this, we have only teclistamab available in India, and it is exorbitantly and prohibitively expensive. It costs about 90 lakhs per year as on date for the patients. Even with the support scheme, we have a lot of cost involved in those treatments, and it is not accessible to most of the Indian patients, even though it's available on paper in India. And coming on to BCMA CAR-T. So if you look at BCMA CAR-T, as Dr. Hemant told, we still are awaiting our Indian products. We have two products on clinical trials in India, which will be approved probably by the end of this year or by next year. We will be having our products. First, we will see the products which are available globally. What is the real data, how it has improved the survival. Basically, there are four products which are approved. Two of them are globally approved by the FDA and EMA, that is ID Captagen Vilucel, which is approved for third line or more. And we have Cilta-Captagen Autolucel, again, it is approved for second line or more. And we have two products from China, which are also BCMA targeted therapies, which are approved by the Chinese NMPA, which is Zivocaptagen and Equicaptagen. So let us see the data for each and every products one by one. So this is a CARTITUDE 1 study design. Basically, they include patients who had at least 3 or more prior lines of therapy, including a PI, IMID, and anti-CD38 therapy. They gave, it's a single arm study. They screened, enrolled, and then they did a leukapheresis, and then went on to give bridging therapy, and then go for cilta-cel infusion after a lymphodepletion. So basically, the endpoints were safety and those and overall response rate. And if you look at the median age of these patients was 61 years. If you look at clearly, there were triple class refractory patients were about 85%, 87 percentage. Penta refractory was 42% of the patients, and almost 99% of the patients were exposed to a prior anti-CD38 therapy. So all of them, almost 99% were refractory to the previous line of therapy. So if you look at the overall response rate was 97 percentage, the stringent CR rate was 82 percentage, and the median PFS was 34.9 months, which is excellent. When we look at patients who are like few months, like 5 to 6 months of PFS has increased to 34.9 months, and the median OS was not reached in this population. The MRD negativity was also very good in these patients. And if you look at this next design is CARTITUDE 4 design. Based on the CARTITUDE 1, they wanted to push the CARTITUDE cilta-cel to the earlier lines of treatment to benefit the patients. This was a randomized control phase 3 trial comparing the cilta-cel in one arm and the standard of care, which is PVD or DPD, in the other arm. So basically, they included prior 1 to 3 lines of therapy, including a PI or IMID, and they looked at a primary P endpoint as PFS. The secondary endpoints were CR rates, overall response rates, the MRD negativity rates, the overall survival, the safety, and patient-reported outcomes. So if you look at the median age, again, was matched, which is 61 years. And in this trial, about 25% of the patients were triple class exposed, and about 6.7% of the patients were pentaclass exposed. Triple class refractory was 14% and 15%, and any PI was seen in about 50% of the patients. So this was earlier line, so we could not see much of a penta-refractory patients because of the earlier line of treatment. So if you look at the PFS in the ITT population, The median PFS was not reached in the Cilta-cel arm versus 11.8 months in the standard of care arms. And the 12-month PFS was 76 versus 49%, which showed an excellent benefit with the use of Cilta-cel group. And the key secondary endpoints, basically looking at the stringent CR with CR rates, it's like about almost 70% of 72% of the patients achieved a CR or better with Cilta-cel, whereas with the standard of care, it was only about 22%. So this is one, the overall response rates were 84 and 67%, and the median duration of the response was not reached. The MRD negativity rates was 60% versus 15%. And OS data is still immature. We need to wait for some more time to look at the OS data. And again, toxicity wise, the patients had about 76% of the patients had CRS. Even though a large number of patients had CRS, they were of lower grade, and only 1% of the patients had a grade 3 or grade 4 CRS, which is manageable. Again, neurotoxicity is 20.5%, all comers and high grade, that is 3 or grade 4 toxicity of neurotoxicity was seen in only 2.8% of patients, and there was no fatal neurotoxicities and very low incidence of CRS, ICANS, and other hematological adverse events with the use of gratitude Cilta-cel. Again, coming into karma, this is the other study, that's ID Captagen. So basically, this is a similar study, like a Cartitude 1 study is a single arm phase 2 study where they included patients who had 3 or more prior lines of treatment, including an IMiD, PI, and anti-CD38 antibody. They look up first, they did the lymphodepletion and then infused the ID cell at various doses. The primary endpoint was overall response rate. The secondary endpoints was complete response rate. Again, duration of response, safety, PFS, OS, PK/PD data, MRD, duration, quality of life. Again, the median EFS in all patients is 61 years. So basically, they had 3 prior lines, and also there are a separate group of patients who had more than or equal to 4 lines of therapy. So on all comers, the median PFS was 61 years, similar to that of Cartitude 1 study. And if you look at refractory status, the triple refractory patients were about 84%, penta-refractory was about 26% of patients. And it also included various extramedullary diseases also. And almost all patients had 94% had the autologous stem cell transplantation. The median follow-up was 24.8 months. The overall response rate was 94%. A CR, stringent CR was seen in 42% of patients. And if you look at outcomes, the median PFS was 8.6 months and median OS was 24.8 months. You could see that the median PFS was slightly lower than this because of the graph. Again, a lot of number of patients were included were more than 4 lines of therapy, 3 lines of therapy. And if you look at the 12-month and 18-month OS was good, like 78 and 65, which is matching the Cartitude study. Again, CRS and neurotoxicity, about 84% of the events patients had CRS, of which most of them were grade 1 or 2. Only about less than 5% of the patients had a grade 3 or grade 4 or grade 5 CRS. And neurotoxicity was seen in about 18% of the patients, of which grade 3 was seen in only about 4% of the patients. So this is based on this Karma 1 study. They did a similar Cartitude 4 like study. Like basically they included patients at 2 to 4 lines of treatment with a phase 3 randomized control trial. And then they had a study arm included the ID cell infusion, and the standard of care arms had investigators had better choice of DVD, DPD, IRD, EPD, and KD. So these were allowed to about 5 standard regimens are allowed in the second in the randomization. They were randomized in 2:1. And again, if you look at the clinical features baseline demographics, about extramedullary disease was seen in 1/4 of the patients. The CD triple class exposed, almost 100% of them were triple class exposed patients when compared to the other study, the less number of triple exposed, and CD38 refractory disease was seen in 95% of patients when compared to that a few patients. The amount of refractory diseases were more in this trial compared to the Cartitude 4 study. So if you look at the overall response rate was 71%, VGPR better was seen in 61 versus 17%. This is what we look at. and CRAs was 44 percentage versus 5 percentage. The median PFS with patients more than with CR was 24 months, and median PFS at final PFS analysis in the intention treat was 13.8 months, and the median duration of response was 14.8 months. And this clearly shows there's a clear separation of curves between the standard and the IDCL arm, which clearly shows that the median PFS of 13.3 months versus 4.4 months, with a hazard risk of 0.49, 50% relative risk reduction in terms of progression or death. And again, the CRS was seen in 89% of the patients, but the grade 3 or 4 CRS are seen in only 7% of the patient. Thus, only about 0.9% of the patients died due to CRS. About that is something which you should keep in mind. Very few numbers had a very advanced CRS. And sorry, you look at the neurological toxicities, again, neurological toxicity is 40% at all grade neurological toxicities, and about grade 3 to 4 was seen in 4.6 percentage, and one patient died due to neurotoxicity. And this also shows that this is a relatively less toxic uh, product. And again, this is zivocaptagen, which is a Chinese product. This is a phase 1 Lumica study. This is tried in fourth line or more. The median age was 59.5 years. Extramedullary disease was seen in about 10 percentage. Dual class refractory was seen 89 percentage. Triple class refractory was 22 percentage, and about 23% at previous stem cell transplantation. And the best overall response rate, if you look at the VGPR rates, was 90 percentage. VGPR better rates was seen in 90 percentage of patients. And again, if you look at all comers, about median follow-up duration was 12 months. And the median PFS was not reached due to the small follow-up of the study. The 9-month PFS was 84 percentage. Any CRs was seen in 90% of the patients, and grade 3 or more toxicity was seen in 6.8 percentage, like CRs, and grade 1 neurotox, very, very less neurotoxic, only 2% had neurotoxicity. The TRM was only 1 percentage. And next comes the equicaptagen, the most recent product, which is approved by the Chinese government, which is a Fumamba study. Again, this is a humanized study. This study, to note that this also included about 15 patients who were previously exposed to CAR T, and about 89% of patients were not exposed to CAR T. The median age was 58 years. The overall response rate was 96%. The CR or better rates was seen in 74% of the patients. The overall response rate was 98.9 in the patients who were not exposed to CAR T, and CR was seen in 78.7% of the patients. This is an immunized CAR T, which is compared to previous ones. And the median PFS was not reached. The 1 year PFS was 78.8 percentage. Again, if you look at the toxicity wise, this is a immunized product. Again, the grade any grade CRS was seen 93%, but so only 1% of them had developed grade 3 or more toxicity CRS. And the grade 1 or 2 neurotoxicity was seen in 1.9% of the patients. We are yet to have the data of our own products, the B-cell. And what are the newer approaches? Basically, there are a lot of dual and triple CAS targeting the SLAM7, GPA-RC5D, and BCMAs are being developed at various laboratories across the world, especially in UK, US, China. A lot of triples and dual CAS have been developed. Addition of checkpoint inverse, but we need to know what is the right time point to add the checkpoint inverse to enhance the efficacy. And trucks is something adding fourth generation cars, which are basically introducing a cytokine receptor, it's a cytokine gene into the car model. Again, addition of CAR T engager molecules. This is something which is novel. Basically, this is CAR T engager molecules or engages the CAR T like BITE. They engage the CAR Ts into the myeloma cells, which are also under research. An addition of other targeted agents to enhance the efficacy, like BTK inhibitors, PI3K inhibitors, like duvelisib, idelalisib, JAK2 inhibitors, lenalidomide, venetoclax, all under research to enhance the efficacy. And at last, the allogeneic CAR T is still in the very nascent mode in myeloma, is yet to come into the myeloma picture. Thank you. I'll be happy to answer questions. Suman sir?
Dr. Sumant, can you take over, please? Sumant, are you there? Okay, I don't know. Maybe he must be around somewhere here and there. Can you hear me? Am I audible?
Yes, sir, you're audible, sir.
Yes, sir.
So, Sumant, are you there? Okay,
Ye-
so I think we've just heard a wonderful presentation from Dr. Jayachandran, and we will take the questions during the panel. But if there are some
Okay.
any burning questions, then please go ahead, raise your hand or post on the chat box, and we will read those and get back to you. So maybe we can continue the program, and the next faculty for all of you is none other than Dr. Manju Sengar. And all of you know Manju. She is the Chief of Adult Hematology Services at the Tata Memorial Cancer Center in Mumbai. And she is going to be moderating a panel discussion on relapse refractory multiple myeloma. What are the treatment strategies in 2025? So, Manju, will you introduce your panelists? Over to you.
Yes, sir. Thank you so much. Thank you, sir and Dr. Sumant, for this opportunity. And Jay Chandran, that was really an amazing overview of CAR T cell therapy. So
Thank you,
with
sir.
me in this panel, we have Dr. Hari Menon, who's from the St. John's Hospital. I think this is an older designation here. And Dr. Prashant Mehta, who's from Amrita Institute of Medical Sciences, Faridabad. I don't think I need to give their designation completely. I am sure everyone knows them well. Dr. Biswajit Dubashi from JIPMER Pondicherry. You can move to the next slide. Dr. Ankit Batra from IMS Dehradun. Dr. Sachin Jain from GeneFlow Labs, Gurgaon. Hasmukh couldn't join us. He's not keeping well. And Dr. Abhishek Dudhatra from HCG Hospital, Ahmedabad. I think he's in some other meeting parallelly trying to multitask. So welcome everybody on this panel. What I'll do, I'll just share my presentation. I've not kept the questions targeted towards any one person. Though I will just, because it's a Zoom, it's not really an in-person meeting, so it may become a little chaotic. So I may point out, individual panelists, but please feel free to, take up any question if in case, I haven't taken out, I haven't, pointed your name for that. So I'll just share my screen. So we'll begin with, some important concepts. And I would request Prashant, if you, want to take up this question first, that how do you define in your practice relapsed refractory multiple myeloma? Prashant, I hope I'm audible.
Yeah, so
Yeah.
we generally use the IMWG criteria for defining relapse, and for obviously patients who are symptomatic, definitely we label them as relapsed, and biochemically use the IMWG criteria for relapse, and refractory, as Jay Chandran also explained, that they could be actually refractory to three classes like triple class exposed or refractory, or they could be penta drug refractory, which could include len, poma, and carfilzomib, and bortezomib and daratumumab. So this is the way we define triple class or double class, or triple class and penta drug. So that is how we define our patients.
Thanks, Prashant. Anyone else wants to, add to this?
So yes, as Prashant mentioned about the INWG criteria, but there are various situations where we would talk about relapse, and it can be after having had, when you talk about typically relapse disease, it could be after having achieved a VGPR, who are on maintenance therapy, who has serological progression or biochemical, not serological, but biochemical progression, or onset of new lesions, extramedullary disease. All these things would be categorized as a relapsed disease. And primarily a refractory disease strictly would be a patient who has probably not achieved even a partial response and who progresses primarily on the initial treatment. And when we are talking about it's important for us to define patients who are, whether they have refractory, penta-refractory, triple refractory, or even refractory to primary treatment, primarily because the outcomes for these patients considerably vary in terms of their responses to any particular line of therapy. And as we all know, that when you have a triple class refractory disease, their outcomes are uh, very short in terms of their progression-free survival, which can range as low as around 2.5 to 3 months to whatever line of therapy that we need to do. So it becomes important for us to also define at what level of refractoriness the patient has, or at what time point the patient has relapsed after a specific treatment.
Thanks, Hari. So as Prashant and Hari both sort of complemented the definition of relapsed refractory myeloma, what I just wanted to bring in from this discussion is that when we talk about relapse, meaning it's a disease which is coming back after therapy. So you've had a response, the response is maintained for more than 60 days, and it can be even longer, and then the disease is coming back. The relapse could be clinical, relapse could be biochemical relapse. So that's something which we need to think through when we plan for treatment. And similarly, within this relapse category, you have a whole lot of diseases clubbed together, whether the relapse has happened after a very good partial response, or a relapse has happened from complete response, or an MRD negative CR, or the patient has had just progressive disease on the last therapy which has been given, or the disease is refractory, meaning there was minimal response or no response to the last treatment, or the most challenging category is likely, other than the penta-refractory category, is the primary refractory disease, where with the first-line treatment itself, even with the dual agents or the triplets which are being used, the disease progresses. So what I just want to put this in front, because the reason, how we need to interpret the data for any of the regimen going forward when we decide treatment for these patients, it's important to know that what are we handling and what are the kind of patients which have been included in those trials. Are these truly, relapsed and refractory patients, or it's just a relapsed disease? And as Jayachandran mentioned in his talk, that whether we are talking of just these patients who have been exposed or they are truly refractory. And if there is variation in the inclusion criteria, the responses may just vary from your novel therapy, which we are looking at in terms of clinical trials, because you either had a bad biology or you had a good biology disease. And therefore, we do need to keep in mind when we compare regimens across the trial or results across the trial. So this is an important point to remember, that how long the response and how deep the response was to the previous therapy, what treatment the patient responded to, and when was the drug stopped. As I said, whether it's exposed or refractory disease, and whether we are talking of relapse after 3 lines of treatment or 4 lines of treatment or 6 lines of treatment, given that there are so many treatment options. All this is very variable, and it helps in making decisions as well as interpreting the data. So if I move to Biswajit, what workup do you do when you see a patient with relapsed refractory myeloma in your setting?
So I would initially ask for a chemogram. Then I would do the biochemical markers like the immunoelectrophoresis, along with the immunofixation and the serum free light chain assay. And then would also do a bone marrow aspiration and biopsy. I routinely don't do a repeat cytogenetics. If already you have a cytogenetics done, generally in routine I do not do. And yeah, this would be, and then obviously the calcium levels and renal function tests, and also imaging for the bone disease, usually a PET CT scan.
Sure. I think that pretty much sums up. Anyone has any difference of opinion in terms of the workup which needs to be done at the time of relapse?
So generally, at the time of relapse, we actually look at with what symptom that the patient came, and our first investigation would be targeting what is the mode of relapse that the patient has, or what is the symptomatology the patient has. Because normally, when patients are on follow up, we generally have their serological markers done on a regular basis, and we are able to pick up those biochemical relapses quite frequently. But in order to augment or try to give more credibility to what are the other sites of relapse, then that will govern the kind of investigations that we need to do at the time of relapse. And I fully agree with what Biswajit had to say. It's pretty much similar to what we would do in terms of investigating a primary disease at the time. And the only thing is whether we are looking, for example, if you're looking at an MRD kind of a relapse, we don't do those things actually, isn't it, as part of a routine investigation. And neither do we do cytogenetic analysis unless it is part of a research protocol or do fish analysis. We don't do any sort of those tests because it does not significantly change the way that you need to manage the patient.
Anyone from the lab perspective that they feel any difference of opinion in terms of need for doing a fish in these patients?
Can I come in? Hemant Malhotra, Jaipur.
Yes, sir. Yes, sir. You're part of panel.
Thanks. So I think one important thing which also needs to be done is a very careful assessment of toxicities of the previous treatment, and particularly, neuropathy, uncontrolled diabetes, corticosteroid related other issues. So that also needs to be very carefully assessed and documented, right?
Absolutely. Meaning previous therapy toxicities and the current frailty and comorbidities are going to be one of the important factors to decide how we proceed with treatment. So anyone for repeating a fish? If yes, we can discuss. Otherwise, we can move ahead with what the data says.
Again, as Dr. Harimanan has told, fish may not be giving you, maybe there be a secondary abnormality which may be picked up, like a secondary abnormality like P53. Second, it may be picked up, but we are not going to change the treatment based on that in the second relapse or subsequent relapses. It may be useful in a research protocol, but may not be in a day-to-day practice. So I also don't routinely practice a fish, because it's not going to help.
So this is just something which as I was preparing for this is something recently, come up, and looking at the outcomes, overall survival for these patients, almost 15 to 20% of patients acquire high-risk abnormalities as they progress from newly diagnosed disease to different, as they progress on different lines of therapy. And if you look at it, if they have no abnormality, no high-risk abnormality versus having two, high-risk abnormality, the survival difference is almost, 3 times in those who do not have abnormality. So yes, for prognostic purposes, it's important. But I think from the therapy selection point of view, unless we are looking at probably a relapse where there are still multiple treatment options which are available, meaning relatively earlier, relapses, probably having a, double hit disease would make us use agents which are more effective, and maybe using, a triplet or a quadruplet if there is a prospect of these patients tolerating the treatment. And I think the only other place where cytogenetics of fish may be helpful is if you pick up the 11-14 at the time of relapse, because that's only subset where, venetoclax-based therapy can be considered. Because for the rest, we know that, it only increases the toxicity. In fact, the survival is much poorer for, patients if they are given venetoclax-based combination over and above the regular combination. So I agree with all of you that, as of now, the practice remains that we don't do it. But if there is a feasibility for using multi-agent, therapy, and which are, in the earlier lines, then we can think in terms of doing a cytogenetics, because that may help in controlling the disease better. However, having said that, most of the people who would have high risk abnormality, especially double hit, they usually have an aggressive presentation also. And so, you would see that the clinical manifestations itself tell us that it's not a good biology disease, and you would need, more aggressive therapy here for this subgroup of patients.
So
Uh,
just to, if I may interrupt, yes, I fully agree. I do ask for fish analysis if I do not have a baseline cytogenetic profile of the patient, most certainly. And as you rightly said, the 11-14 translocation becomes an important I think if you don't know to ascertain whether that exists, because it's an effective treatment in the relapse setting.
Can I ask one question?
Just want to give a disclaimer. I'm not able to see all of you, so please do unmute your mic and speak.
Can I ask one question, Prashant, this side?
Yeah, please go ahead.
So, I just wanted to understand if anybody is doing NGS at later relapses, because there's a common pathway which is mutated, BRAF-MEK, and 5% have BRAF alterations which can be targetable. So, is anybody doing? I have done sometimes, and there was one particular patient. One of my colleagues emailed Dr. Shaji Kumar, and he replied that please look at this BRAF also, and maybe you could add a BRAF inhibitor. So, is anybody looking at this particular pathway, with NGS?
So at our center, we don't do it.
I don't think I've ever asked for NGS so far. We don't know what happened in the future, but no, we don't.
No.
I understand the thinking, Prashant, that when you have failed almost all the options and you are looking at something, probably in that situation, you can think in terms of doing an NGS to find a target. But I think if you look at unselected populations, especially when they are not heavily pre-treated, I think that's a situation where we wouldn't do NGS as of now. But point well taken that this can be explored as we start understanding the biology more and more, and especially biology being corroborated with prediction for treatment response. I think it's something which we can look forward to in future.
Thank you.
Okay, so we'll move from these theoretical discussion to actual issues which we face with these cases. So this is a 54-year-old male who's a known diabetic, seems to be fairly well controlled. Diagnosed with myeloma, ISS3 at that time, standard risk, with renal dysfunction. There was light chain disease, predominantly it was a lambda light chain disease. In view of renal dysfunction in the beginning, started with bortezomib, cycloindexa, and then after one cycle, once the renal function started improving, changed to bortezomib, lendexa. And post cycle 4, he attained very good partial response, creatinine normalized. He underwent a transplant and then len maintenance, which was started from late 2018 onwards. However, 3 years later, sometime in late 2021 and early 2022, it had to be stopped because of cytopenias, and he started developing repeated infections. So that was stopped. Remained well for close to 24 months after stopping the lenalidomide, but sometime in the early 2024 started showing there was a rise in free light chain assay again, with again lambda light chain increasing to 120 and kappa was 25. There were no other features. This time the renal functions were normal and there was no other bone pain. Evaluation did not reveal anything. The bone marrow aspirate had plasma cells which were around 20%. So the question is, how would you approach a situation like this? And maybe I can start with Abhishek, Dr. Abhishek. Yeah, if he's, yes.
He's not there. Some.
Okay, I can go to Dr. Ankit. Is Ankit around?
No, he's having some technical. He just got out.
Okay. Is Dr. Samir here?
Dr. Sachin is here. No.
Okay, hi, Dr. Sachin. Yeah, Dr. Sachin. Sorry, I've been trying to move up and down on the Zoom and see all of that.
Ma'am, I'm actually hematopathologist, so I think better to pass on this question to any clinician.
Okay, so I'll then.
I'll take up. I'll take up. Sir.
Yeah.
Okay. Basically, Jayashandra. So in this patient, I would just closely keep an observation for, because the plasma cells is also 20%, and I'll
One more, then we will.
hello. So sorry. So
No, no,
I would think about keeping the patient under observation. If the patient is not having I would do a skeletal survey to look for new lesions. If there's any symptomatic lesions, I would ask then skeletal survey, and I will keep the patient under close observation because this is a biochemical relapse. And but I would frequently see the patient more frequently rather than having him under regular maintenance, regular follow up of 3 months once or for 6 months once. I would reduce the follow up duration to 2 months once, and then ask him to report as soon as if there's any sum of symptoms. So this is what I would do in my practice rather than taking up the patient for treatment after first line.
any difference of opinion from anyone?
No, I would agree to several, but we know about this concept of free light chain. It just is a prelude to a frank relapse. And if the patient does not have too many symptoms, we know that the patient will require treatment in the near future. But certainly there should be an attempt to look at other aspects of relapse in terms of skeletal disease progression, or even for that matter, it should trigger a bone marrow analysis also over here to see whether there is bone marrow plasmacytosis, which will help us decide whether we need to treat the patient or not. So definitely this patient is likely to relapse in the near future. The option of keeping him under close follow-up is there, but we need to take that decision only after having a full workup to see whether there is a underlying a relapse that is still not manifested in terms of symptoms.
Prashant,
Sorry,
Prashant.
Biswajit here. Yeah, I just wanted to know this 25 is kappa and 120 is lambda. Is that correct?
Yes.
So the involved versus non-involved is less than 100. So you need not even have to do any testing also for, I mean, if the patient is asymptomatic, no need to do even marrow. At this point of thing, nothing to do because it's not even cross 100. So I will not just do anything. I just keep under follow-up and repeat the test probably after 2 or 3 months.
Any difference of opinion from anyone?
Oh, ma'am, I just want to ask, how many of us we are doing using the flow MRD in these type of cases? Because flow MRD in myeloma is a very sensitive technique. We can go up to 10 to the power -5, means 0.001 if we are using 8 to 10 million events. So that's a quite sensitive technique. Like in BLL and AMLs, BLLs we are doing very frequently. Everyone is using it. So how do you see the role of myeloma MRD by flow, because it has come now in international guidelines also? So
we don't treat
in this particular patient. Sorry, Jayachandran, you were saying something.
No, please.
Yeah,
no, please, you go ahead, ma'am.
Yeah, in this particular patient, I don't think the treatment decision is going to be made by flow MRD. Lambda, he had lambda light chain disease in the beginning, and again the lambda light chains are rising. And let's presume that even if the flow MRD was positive and if the light chains were normal, the other renal functions were normal, we wouldn't treat, because the ultimate intent is that treatment in biochemical relapse in a certain set of patients and otherwise clinical relapse. So flow MRD is only for response assessment, and many of us are using as in terms of more of a research protocols, rather than actually basing treatment decisions as of now on flow MRD, even in the frontline therapy. So, once at the time when we are starting.
I think you told the bone marrow had 20% plasma cells.
Yeah,
I think in that case, I think obviously.
Okay, sorry, I did not.
Probably.
Yeah, okay. If 20%, then yes. Okay.
Yeah.
20% plasma cells. So again, MRD would be obviously positive in this patient.
Scenario.
But just wanted to know that why did we ask for a bone marrow if it was less than 100? I don't know. If the patient was not symptomatic.
Correct. So the free light chain assay was completely normal for all these years. Throughout, post-transplant and Len maintenance, and even after, up till this value, it was within normal range. But this time it started rising. It used to be roughly around, 25 and 30 used to be the range, and it became 120 for this patient. And given
And do
that
you
at
act
the
upon,
time,
sorry, ma'am. Do
sorry,
you
go
act
ahead.
upon a single value of lambda chain, madam?
No, no,
No,
no,
no, no.
Yeah,
So
always you
typically,
look at other value, second value.
no, no, not at all, not at all.
correct.
Yeah,
So
yeah.
we typically, when we see one value in a person who's been otherwise bang normal range, and we just get one value which is elevated, we call them back again and we repeat the value. Not immediately. Typically, if all the other clinical parameters are within normal limit, we see them somewhere around 4 to 6 weeks later and see what is the status, whether they're rising, again the same value, the similar value is coming or not. So this was more, basically on 2 occasions, we started seeing the rising trend, and that's when we, did the marrow. The
It's
worry here
important to
was
tell the
because
residents.
yeah,
The
because
important to tell the residents there must be no reflex seeing a single value.
correct,
A lot of
correct,
people get very much afraid and then start evaluating the patient. You should all
correct.
tell them if the patient is
Yeah,
asymptomatic, see a single value of altered SFLC, then we should also always think about waiting and then repeating a value after 4 weeks to know whether really it's a laboratory excursion or something else.
yeah. The only thing which we need to be careful here, because this person had presented with renal failure in the beginning, and if the
Right.
disease now is a bit aggressive, then very high chance that if we wait for a longer time and call him for the regular next follow-up, there's a very high chance that he may come back with the renal dysfunction again. So that's one point I wanted to convey from this case, that though many times we, look at the biochemical relapse and we say, okay, we'll keep under observation if there is no significant symptom, if there is no CRAB feature. But if you see patients who had presented earlier with renal failure, especially the people who had high-risk cytogenetics, and if you start seeing that, they have rising free light chain, or for that matter, rising M-band, be sure that you are following up these patients closely. You inform them that what is the relevance of follow-up, because once they come up with one of these end organ damage, that it can be crippling, and that can compromise your further therapy and outcomes. And the other point is somebody who's had an extensive bone disease in the beginning, they can come with fracture if you just don't educate them well, and if you start seeing these kind of serological relapse. So
Just can I just is just again reiterates the fact that we need to know what the patient had presented, what were the problems at baseline the patient has, wherein we will trigger our requirements to take a decision whether much quicker or later on based on what the end organ damage, etc., can be for this patient. That's an important learning thing that we need to understand.
just wanted to check, do we take questions now, or we finish this and then we take questions? Because I can see that there are almost 4 questions on the Q&A.
Ma'am, totally your choice, ma'am.
Okay, so let me finish this case and then we can, take the question. So we, like everyone, we followed this patient. Roughly 6 weeks later, the patient came back, and this time the free light chain assays have gone up and they are now in thousands. So my question is, this is a patient.
The slide has not moved, man. The slide has not moved.
I'm just giving you a scenario.
Okay, sure. Oh, sorry.
I'm going to discuss a lot of things on this. So,
Okay, I thought this.
Yeah. So this patient's free light chain assay started to rise further, and though fortunately the creatinine did not increase when he came back, roughly 6 to 8 weeks from the last follow-up. So this is a situation where we are looking at somebody who's received VRD, received transplant, and then LEN maintenance, remained well, 2 years after the LEN maintenance was stopped because of the poor tolerance. So my question is, how do you approach this patient now? And again, anyone can take it. Biswajit, you want to go first this time?
Yeah. It depends on the finance also. So options, my first option, if there is no financial restriction, anything, then would be to go with daratumumab based therapy. And option will be to give a 3-drug regime, which would be Dara, Len, Dexa is one option. But the problem with Len is that patient also had a lot of cytopenias and the tolerance was not clear. So that part of the history needs to be checked, is about the tolerance to Len. But if there is also toxicity to len, I'm not sure. Also, there may be a toxicity to pomalidomide. So both the IMIDs might be slightly difficult to give. So Dara Dexa without giving IMID is something, one possibility. Otherwise, I'm not sure whether in this situation cyclophosphamide with Dara Dexa, I'm not sure that it's any data for that. So the challenge would be to add in the IMID. Dara and Dexa definite and the IMID. If daratumumab is not an cannot afford and is not an option, then I would change the PI. So it would be carfilzomib, dexamethasone 2 drug. Again, the same problem will be with the IMID. So I'm not sure about the IMID. We need to look at the history, what was the reason and the dose at which the patient developed pancytopenia.
Anyone else has anything to add?
So, I mean, I would agree with almost everything that Biswajit said. But over here, because 2 years have elapsed since he developed and has had this progression of the disease, we have the choice of either using a combination of daratumumab with a PI and DEXA, or even for that matter, using an IMID, because he's not been on an IMID for the last 2 years. But my only thing would be my choice of drug may skew towards using a proteasome inhibitor if he has any form of renal impairment. That's all.
Anyone else has
Why not DVD, madam? DVD is also an option because it's exposed to Velcade, not refractory to Velcade. So DVD kit or daratumumab, carfilzomib, dexamethasone also can be exposed. So again, as Dr. Harisa told, I will expose the patient again to len. I think we have seen patients who were having the same cytopenia issues. When we re-expose them to len or POM, they seem to tolerance at that point of time did not have much of issues.
So the data from both the Castor and the Pollock study and all the other studies would give credence to using any of these things, but the rate limiting thing would be for using proteasome, maybe, if at all, whether there is a renal impairment. That's all.
So this patient at the time of presentation now does not have renal impairment. My question to all of you: he has been exposed to bortezomib almost 5 years back, responded very well. So he's exposed, but not not sensitive. Disease is not sensitive. In fact, there has been a long gap. Even for lenalidomide, the response was there. The reason for stopping was toxicity, which many times we see post-transplant. That's a challenge. And once you reinitiate some of these treatments at the time of relapse, either the same IMID or a different IMID, you don't get those cytopenias very often. So that's something which is there. So any thoughts on re-challenging with bortezomib, len, and dexa? It's been a long time. I know that there is good data for DARA if you look at the kind of patients, but kind of these studies which are there, the DARA combination.
5 years ago we were doing it. 5 years ago we were doing it, madam. Not now with our
what stops it now? What stops it now?
If nothing is available for
I have something to say there. The whole school of thought for myeloma now has moved from saving your best for the last to using it early, and that is a general thought process change in myeloma overall. But I do agree that in the Indian setting, we can still utilize some of these therapies again and still hold on to our later lines and fight the marathon, run the marathon rather than making it a short battle.
I would think that there is really no issue in us rechalling with bortezomib, and it's quite likely, given the way that the patient has gone on for so long, it's likely that he will respond to that. But always we have to look at the data, and the data would skew us towards using daratumumab over here. That is all, nothing else.
There is no OS benefit. It's mainly the PFS benefit. So there is nothing wrong in actually doing BRD also. I mean,
there is
because you could re-challenge after that.
My reason.
And also there is, I was looking up the meta-analysis yesterday, published yesterday, which showed an OS advantage of multiple trials. It was just yesterday I found it somewhere. But it is a meta-analysis of many trials.
So that's where our problem is. Then when we don't find of what is the question. So what I just wanted to bring in here is that if you look at all these studies, patients who are Len refractory, this patient is Len refractory because the patient has been off Len for quite some. Applying the data to our patient, and that's why I was bringing up the point in the first slide that not all relapses are similar. We are looking at patient who. And I'm really not sure because the description of patients included in these trials often doesn't provide such granularity. How many were answer is yes. You should think in terms of data-based, combination. A triplet maybe questionable OS, which we were discussing. So, but I feel that instead of using another agent, because this is again my perception and probably the frontline trial of comparing the carfil with bortezomib, I'm really not sure carfilzomib is any better than bortezomib. And the second thing is POM and lenalidomide. I would reserve POM for a later because we know that if the disease comes back later, we can say lenalidomide if the patient is only Len exposed and not Len refractory. So these are some of the thoughts. Maybe we can take the questions before we move on to one more case if we can cover. Dr. Sumant, your permission.
Ma'am, totally your call. If we can finish in next 10-15 minutes, it will be enlightening for us. Yeah.
Okay. So there is a question from the audience and anyone can take it. What is the role of PET-CT imaging regarding the diagnosis, evaluation, and response to therapy? Prashant, you want to take it?
Getting a call, sorry, from emergency. Hello.
Oh, sorry.
Yeah,
Hari, you want to take it?
so when we talk about responses in terms of achieving a CR, we have three independent entities. One is the biochemical, the other one is the bone marrow MRD, and the third one is, of course, the radiological features. So that is just one aspect of the treatment, and it depends upon about the status. If we have done a PET scan assessment earlier, and that is a yardstick for us to assess, definitely it has its significance, and it has to be exercised wherever it is relevant. So I would say it's an important aspect to look in for assessing responses to a particular treatment, to a particularly defined treatment. And it is something that is useful in determining complete responses in a patient to a defined therapy. Did I answer that question right? Because I didn't get the question correctly.
The question was PET-CT at diagnosis and response.
I think it is part. I think it is part of the workup nowadays for most patients, and it becomes a easy investigation to look at to determine the extent of skeletal disease, particularly extramedullary disease. And it becomes extremely important when we are assessing plasmacytomas for us to understand the extent, because that will determine whether we need to treat it like a solitary plasmacytoma or whether it is a myeloma. So in these specific situations, they become extremely crucial, but nowadays it has become part and parcel of primary evaluation of a myeloma. Even in terms of the post-transplant setting in these patients, PET negativity PET negativity post-transplant is an important prognostic marker. So if we have those things in our, those understanding, then it becomes useful. Yes.
One more point I want to add, madam. Basically, interpretation of PET scan earlier when you have is very important. So you may have a lot of sclerosis, increased PET uptake at some point of time. So it should not be taken away by interpretation of those scans. Very importantly, if the PET-CT is not reported by a proper person who is seeing the routine myeloma PET-CT responses, will be taken away by reports of higher PET activity and sclerosis causing the more pet activity. So we should be always interpretation of response, especially when you see the response after 4 cycles of VRD, you tend to see a lot of this increased pet activity due to bone formation. So that we should keep in mind when we keep the response assessment.
So that's why there are now standard protocols for reporting PET scans in myeloma. It can be quite
I'll just,
cumbersome. It can be quite cumbersome, but it is.
I'll just summarize, maybe we can move on to the next question. So just to summarize that, if you have a solitary plasmacytoma, you're looking for other sites, yes, you can do a PET scan. If you're looking at smoldering myeloma, and if you don't have a whole MRI, whole body MRI to look at whether there is that one particular lesion which is going to be a myeloma defining event, then in that case you can look at PET CT. For response, answer is yes, you can look at response if you're looking at responses in terms of plasmacytomas or bone disease. But keep in mind, as everyone said, that there are false positives and false negatives. Largely because of steroids, you can get a false negative scan. So you do need to be mindful when you are looking at PET CT for response. So for most of us, unless they're part of clinical trial, the assessment involves looking at serum protein electrophoresis and looking at immunofixation and free light chain assay, and marrow if you're trying to think in terms of taking them up for transplant or subsequent follow-up. So that's where the response comes in. There's a question which looks at whether there is T53 clone which appear or expand and relapse, whether that's going to have impact on treatment options at the time when the disease relapses or is refractory. Anyone?
I think we have answered this question, madam. So it may have a second hit or the clone may expand, but there is no predictive implications on treatment as of now. Maybe we have only prognostic implications. So that's it. We already have discussed this point, I think so.
So I think the next question is if there is any specific time between treatment and relapse that we can say recurrent relapse for shorter duration could be refractory case myeloma. I think the question is time when the person relapses. So the definition is 60 days or, there is minimal response and there is progression after that. So that's where it becomes refractory. The last question, I'm really not sure what it is. So I'll just, move on. We'll just take the last case very quickly to just touch upon what the alternatives are for somebody in the current scenario when you see relatively aggressive relapse. So this is a 60-year-old female, had double hit myeloma in the beginning, that is 414 translocation and 17P. Received DARA-VRD as induction in the beginning. And now, after 4 cycles, she denied ASCT and continued on therapy. But after 1 year of therapy, she experiences progression. So how would you approach? Prashant, if you're back, you can take it, or anyone else can take it. Yeah.
Oh, I think this patient has got a quadruplet earlier. So for her, and she has progressed early. So I think, and she did not take any, did she take any maintenance also with Dara? Continued
It
on.
was continued.
She was
Therapy
already,
was continued.
she was
Yeah,
on.
yeah.
So she's,
Yeah.
she's refractory and she's triple class refractory, it seems. And now a pomalidomide based combination may be an option, but I think the preferred options would be again between the, BCMA targeted therapies and the GPCR 5D targeted therapy and the CAR-T. So that will come in now in this particular patient. And other options would be something based on carfilzomib and pomalidomide. And now I would really want to check the extramedullary disease status also, because this patient would be probably at high risk of extramedullary progression also. So all that assessment will have to be done with respect to the whole scenario. What is the status of disease and what are the organs at risk, and is there organ involvement? Does this patient have any renal involvement also?
So at present, it's only the serological progression. There
Okay.
is no renal involvement.
And as
There is no neuropathy from the bortezomib. Tolerance to therapy has been reasonably well, despite it's a 60 female. But tolerance to therapy has been reasonably well. Anyone else has any other opinion?
Actually, when we look at this, the fate of this patient has already been defined, and it is not like as if whatever we had done in terms of, she has received probably the best available regimen, which is currently available. And I don't think transplant would have changed anything either over here. So these are the patients whom we have to pick up early, double hit lymphoma, and prognosticate in terms of what is going to happen to the patient over here, because the patient has relapsed within 1 year and is expected. So what we must understand is no amount of any sort of anti-myeloma therapy from here on is going to make a significant change other than to temporarily control the disease to a certain extent. And these are the patients who may have to go for a cellular therapy, either using a CAR T cell, or for that matter, a bispecific antibody-based therapy over here. Because none of the and even if you look at using daratumumab in these high risk disease, there is no data to say that daratumumab, addition of daratumumab in high risk disease, is going to change things. Though we use it diligently, but there is no data to say that it has changed the way that these the disease actually behaves on the long run.
Sure.
I
Any
absolutely concur, man. I absolutely concur. These are patients for, even KPD may not really work on these patients. These are patients for cellular therapies or BiTE.
Correct. So if we
I
have
think
feasibility
awaiting those cellular therapies and bites, because the patient might not get access immediately.
Yeah.
So you need to bridge him with something, and probably a pomalidomide carfils would be a reasonable bridge. And also between the bites and CAR T, there will be a contention here, because if she's rapidly progressing, she might not be a great candidate for CAR T as well. Rapid progressors don't do as well, so she might need to choose between a BCMA versus GCPRFA5D. And if we are considering CAR T in future, a BCMA bite also would not be a great idea. So maybe you'll have to use something like Talquita first and then keep the BCMA target intact. So you can use a BCMA CAR T later. So there are a lot
So
of
what about
which come in.
What about conventional chemotherapies like PACE?
Yeah. So
Yeah,
I
that
would,
is
you know,
that is a that is
yeah.
a possibility, but not for it. They don't work
So
for long.
that is
So
a
everyone,
but it is not going to bring about a durable response.
Yeah, agreed.
yeah. So everyone's point well taken, but you know, sometimes in this situation, a poor man's therapy of pomalidomide, cyclophosphamide, dexamethasone does help to, you know, keep the disease under check for some time. More so if we don't have feasibility
And
for
look for a clinical trial with Dr. Hari or
Now
any.
that,
yeah.
Sorry, now that we have both the therapies, BiTE as well as CAR. So,
yes. So that's the question which is coming to
would
you.
Be important is whether the CAR comes first or the BiTE comes.
Yes. So that
Whichever
was
is cheaper.
coming to you, Viswajit.
Tough one.
So it's I'm sorry. Oh, Biswajit, go ahead, please. Yeah.
So I think the questions are about between the two. So the advantages of CAR is that you do a one-time therapy and it's a single time you do, whereas the BiTE requires more number of doses. That's one thing. The second thing is, for the CAR, you need to collect the cells and then you need to engineer the cells. So what will happen if you do the BiTE first and then the collections of the CAR after that?
The outcomes are extremely poor in that situation. You don't
in that situation
unless you are following it up with like something like talquetamab.
Correct.
Or
so in that situation, CAR would be first, followed by Teclis.
So the thing is that don't do a CAR after a BCMA based bispecific.
No, first do the CAR and then reserve the BCMA for the.
It doesn't work. It doesn't work.
Does not work
So
because
if you use the same if you use the same
It's a very
targets, again there will be issues, sir. If you use the same target of BCMA BiTE and CAR, any sequence, if you use a BCMA CAR followed by the BCMA BiTE, or if you use the BCMA BiTE followed by BCMA CAR, the second therapy is not going to do a good efficacy. So only you should have use a
change the target.
GPRC5D BiTE followed by BCMA CAR, or BCMA CAR followed by a GPRC5D.
There is data to contrary, Chandran, also that, you know, if people have used CAR T and they have gone on to use BCMA bispecific antibody, and it has shown responses. In fact, many of the early trials.
But that is after some time, madam.
Fully agree. If you want a sequence, that would be the way to sequence it.
Yeah, so because the earlier trials which were there for bispecific antibodies, many CAR failures were taken in, and that time it was mainly the BCMA bispecific. The you know, other bispecifics have come relatively later, And there has been a response even with the BCMA card. But of course, meaning if you have option to choose, plenty of option to choose from, you would prefer that there is a different target which you are looking at. Prashant, your hand is raised. I can see it.
I just want to add the responses are there, but they are diminished and they are not durable. That is the problem. So you're using a such an amazing therapy like CAR-T or expensive therapy also, and then you're doing it for so little. That is something which hurts.
So it's difficult to predict. We
Right now,
know that if you
right now
look
we
at
don't
the
have
CAR-T
talent.
trials, even
The question
yeah,
here.
if you look at the CAR-T.
Sorry, go ahead. Go ahead. Sorry. Yeah.
Well, but I'm saying that if you look at the CAR-T trials, there is, even if you look at the high-risk cytogenetics, there is reasonable response and PFS. In fact, even the MRD negative complete responses. So I think that's a subset which is relatively better, solvable when they relapse and progress. But
So
the
I'm
problem
talking
is,
of
I
a
think
situation where you have
to
used
feel
Eclista and then following up with a BCMA card. That's the situation I'm talking of.
That doesn't work.
Yeah,
It doesn't work.
that
It's
doesn't
not
work.
a
so
recommendation.
there.
If at all we want to use, we need to use it. If you want to use a bispecific, you can use it after a CAR with some
That's
responses.
what.
But the vice versa doesn't work.
And if
Yeah,
if at all you
absolutely.
have to use a
Yeah, so for
specific
theoretical,
before BCMA card, then it has to be talquetamab instead of
That's true.
Eclista.
so for theoretical discussion, answer is yes, that's possible. But for many of the patients, having these two expensive BCMA therapies is practically not feasible. So we need to think through. But answer is yes, that if you have rapidly progressive disease, all the money in the earth available, you would you don't have time for CAR, you would go for bispecific. But if that's not the case, and you have access to CAR-T either in terms of trial or otherwise, then CAR-T. I think there is not much time left now for these drugs, which are
One question
sort
I
of,
have.
towards the
One question.
outer part. Yeah. Prashant, go ahead,
So,
please.
ma'am, as you know, you are also part of the BCMA CAR-T study now, which is now also available for those who are not exposed to anti-CD38. So now, what is your thought on that? Would it be a time in India when this would be also kind of neck and neck with CD38, or it would be after only?
See,
I
increasing.
think we need to
Sorry.
wait for the results. Would be difficult to say that it is going to be. If you look at even the other CAR-T which are approved, they are moving towards more earlier lines of therapy. Though the data is not, other than their frontline therapy, the data is already there for more than one line of therapy. So that they are moving earlier, and probably to do that, to do with the fact that DARA is now, frontline therapy in majority of these patients. DARA-based triplets or quadruplets are being used in those countries where CAR-T is moving to earlier lines of therapy. In our setup, we need to see the proof that it works as good or probably better than DARA, and it's single time therapy. Then answer is yes, that it will be an option for our patients where there is feasibility, because if we're looking at DARA, we are looking at huge expenditure, long period of time, at least till such time the generics come in market. Yeah.
Thank you, ma'am.
So if you look at the Cartitude 4 study, sir, Cartitude 4 study included only 25% of them who were triple class exposed. So the rest of them were not exposed to all the three classes of drugs. So even the multinational trial did not include anti-CD38 as a mandatory CILTA cell trial. So I think we should think about the same when you are moving into earlier lines.
Sure. I think with that, we will end this. You've all been fabulous panelists. Thank you for making the job so much easier and your active contribution. So thank you so much. Handing over to Dr. Suman.
Thank you, ma'am. It is one of the best panel discussions I've heard in recent times. And I think now the best thing will be to hear Dr. Purvesh Parikh, sir, to give us the expert comments and close today's session. Sir, I think no one can do it better than you right now.
Thank you very much, Suman. It's a privilege and honor to be part of this panel discussion, especially after Manju, Hari, Prashant, Jayachandran, and Biswajit have, really thrashed out all the finer points. So it is absolutely a fantastic discussion that we've had. And I think this is an extension of how Indian origin hematologists and oncology are leading the myeloma battle all across the world and especially from the United States. For my concluding comments, I would like to focus only on patients of relapsed refractory multiple myeloma who have failed directly. Now, how do we approach these sort of patients? So there was a lot of discussion on molecular and cytogenetics. But I think a few things that I would like to point out. So while we are trying to prognosticate a patient in translocation 414, the mutations that are upcoming are the FGFR3, PIS3, and PRKD2. As far as the 1114 translocations are concerned, mutations of importance now are CCND1 and IRF4. And as far as the translocation 1416 mutations are concerned, I would look at MAF, BRAF, history, and ATM, as well as hyperdiploidy. And based on this, then, very beautiful discussion happened in the panel versus in CAR T versus BCMA versus bispecific. And I think Silta cell is something that is absolutely useful. And it has, you know, even those patients who did not fulfill the inclusion criteria as per the Cartitude 1 study would still have almost 100% response rate. So I think that is something that we might want to focus on. In addition to these points, what are the new drugs that are available? So linvoseltamab, bispecific BCMA plus CD19 CAR T, teclistamab, belantamab, mafodotin are some of the drugs. And talquetamab is a bispecific, like Jayachandran mentioned, again GPRC5D. And that has shown an overall response rate of as high as 17%, 71% in patients who are triple class exposed, as was mentioned. But there are two new drugs which are in early phase trials and which we should look out for. One is a B cell maturation anti and BCMA directed CAR T therapy, that is ID-cell. And the other one is the GSK 285791, which is again an antibody drug conjugate targeting BCMA. And both of these are in phase 2 studies, and hopefully they will add to the armamentarium that we have against multiple myeloma. So I think even though we might not be able to cure the patient, we are able to give them a prolonged, good quality of life, and that is essentially what we are trying to do as far as the management of multiple myeloma. Uh, Hematopoietic stem cell transplant being replaced and reducing the mortality of the treatment as well as providing quality of life should be the final outcome that we are looking for. With that, I thank you very much for this opportunity and we'll stop here. Over to you, Suman.
Thank you, sir. Thank you for your kind words. So, I'm really thankful to everyone who joined today. And for a topic like multiple myeloma, which is a very narrowed down topic, we had around 175 people listening to us. And I'm really thankful to each and everyone who joined in. Manju ma'am, thanks a lot. I think we had a wonderful session. Dr. Jay Chandran, we thank you for the talk. And I think the one person who deserves a special thank you is our president, Dr. Toprani sir, who sat through the whole session listening to multiple myeloma. Thank
Suman,
you,
can
sir.
I take a minute?
Yes, sir. All yours, sir.
So I told in the evening to Dr. Samir that I might just listen for a few minutes and I might have to leave. But the way the whole session progressed, the way Jayachandran had given his talk, the way Dr. Manju has conducted the panel, I could not resist but listen to the discussion, and this has enlightened me a lot. After a long time, I have heard a team of medical oncologists and the hematologists discuss the topic. And I must congratulate all the panelists, moderators, and the speakers. And I thank all of you to have agreed to be a part of the ISO scientific program. I also thank Dr. Purish Parikh to be available for this meeting. And this was a landmark meeting in the sense that this was the, I think, Suman, correct me if I'm wrong, this was the only meeting where a pure hematology or medical oncology topic was selected for the ISO webinar.
Yes, sir.
And I'm happy that more than 200 people have participated in this webinar today. My only request to all the panelists and the faculties, please be an integral part of the ISO and strengthen the organization, because ISO is a multidisciplinary group and we need more participation from the hemat-oncology, medical oncology, and the radiation oncology apart from the service. So thank you all, and over to you, Sumant.
Thank you, sir. Thank you for kind words. And a special thanks to Professor Hemant Malhotra, sir, who guided this webinar, who was very kind to give his time, his inputs, and in coordinating the faculty. Thank you, sir, for your help. And thank you, Pravesh, sir, for giving us the expert comments. So, have a very great.
Thank you, Sumant. I second your opinion and Dr. Tokrani that this has been one of the best panel discussions which I've had the privilege to witness, and great talks by Dr. Ramchandran and wonderful moderation by my pleasure to witness this. Thank you.
Thank you, sir. Have a good night. Thank you, everyone. Thank you for
Thank you.
joining
Thank you.
us.
Thank you.
Bye. Good night.
Thank you.
Good night.
Good night.